For over 20 years, Clinics Health Group has provided world-class healthcare to underserviced communities. With every new facility we open, quality, affordability, and excellence is what we've become synonymous with. To that end, Cullinan Wellness Hospital is the latest addition to the group and the third in our growing roster of psychiatric care services. Located in Cullinan, east of Pretoria, our state-of-the-art facility is perfectly suited to service patients as far as Mpumalanga, Limpopo, and the Northwest Province in a tranquil setting surrounded by a luscious garden and mountain views.
It's very important for us to have such facilities in our communities because previously we've ignored the psychological instability. We thought we can go on with stress or depression, and because now that we have come out as psychiatric faculty to say we can offer this kind of care, treatment and rehabilitation for people who are in need of, who needs to heal emotionally or psychologically. So these kind of facilities are important to be. I would wish that every area would have this kind of wellness facilities.
I think mental health institutions and wellness centers such as this one are important mainly because we live a very rat race type of life and struggle to see when we are truly struggling with life. And being able to come into a facility like this allows one to pause and acknowledge whatever is happening in your life that is bringing you down, pause and regain function, pause and get back onto your feet in a way that you didn't even realize you needed. There's the need to have an out of your comfort zone area that will move and shake you as much as possible to get you back into a better state of you.
No matter the treatment or duration of stay at Cullinan Wellness Hospital, our patients and their loved ones can rest assured that they will be taken care of and watched over by our team of experienced mental health nurses, psychiatrists, and clinical psychologists.
Most of the patients that we admit are voluntary patients and they come on their own. The diagnosis that we normally work around is that patients with bipolar mood disorder, major depressive disorders, as well as post-traumatic stress disorders. Some has personality disorders such as gambling.
Our hospital provides private psychiatric services that aim to help the individual experience the fullness of life. We cater for a wide range of patients, including those with depression, bipolar, post-traumatic stress disorders, anxiety disorders, sleeping difficulties, neurocognitive disorders, dementia, and psychiatric conditions, amongst others.
My approach is I use what we call cognitive behavioral therapy, CBT. So basically it's helping because most of the time I've noticed that we tend to be depressed or go into mental problems because of the channeling of our thoughts. We tend to think if you are going through a difficult situation, you tend to think more negative about it than thinking positive about it and actually getting a solution. So I just help my patients to come up with solutions, and hence I use solution-focused therapy because I'm confident that they do have solutions. It's just that sometimes they're not confident to put them into action.
My approach when treating a patient goes back to the good old Batupele principles. We follow a very client-centered approach. Every case is different, and so applying Batupele principles where it's about the patient, it's about dignity, it's about ensuring that the patient's needs are met, is at the core of practice, is at the core of all intervention.
As mental health practitioners, we encourage individuals to visit our facility so we can assist them in finding routine solutions to the problems they face on a day-to-day basis.
I think from a very simple point of a non-functional mind is a non-functional human. And neglecting mental health means, in essence, neglecting a whole part of yourself that is very necessary to maintain function on a day-to-day. The more we ignore the brain and the psychology and the emotions of a person as we have been, the more we are likely to not reach to the full potential that we could.
At Clinics Kaplan Wellness Hospital, we believe mental health is the cornerstone to helping you find and lead a happy, balanced life. Visit our magnificent facility at Hospital Road, Cullinan, Pretoria East. We're open 7 days a week and are ready to receive you.
Good evening. Thank you, colleagues, and welcome once more to our Clinics Health Group weekly webinars. That was our mental health wellness unit Cullinan Hospital based in Pretoria, East Pretoria. And we, as the last person to speak, they will say, please do visit our hospital, and all those healthcare providers who see patients who need attention at a wellness facility, please do make use of this facility that we have at Kaplan. And thanks once more, and we appreciate your support that you are here with us every week as we endeavor to bring you top speakers, specialists in their own fields, in their chosen fields where they've been trained and have got quite a number of years of experience in providing healthcare and teaching in those specific fields. And so we just want to say thank you for the support. We've been doing this webinars for the last 2 years since the lockdown started. And we found this to be a good platform to engage with all the healthcare providers across the country, and also people who are associated with Clinics Health Group and those who want to introduce it to Clinics Health Group. And so this is one of those evenings, and we're excited that even this evening, for the first time, we are partnering with a pharmaceutical company, most of you who are with us this evening. And before we start, I'll just give Dr. Dineo just a few minutes to say 1 or 2 words as we start the webinar this evening. Please do note that these webinars are CPD accredited, and also we are live on YouTube. And so when you, as usual, when you log in, make sure that when you register, you provide us with your full details, your registration number, your HPCSA, SANC, or Pharmacy Council, or allied health professionals councils that you're registered with, so that we can then provide you with the CPD points. And also those who are not yet on our database, please indicate if you are not receiving invitations via email, because we want to provide you with all information, invitations. And please indicate if you want us to put you in the database. I see that people are writing their details on the WhatsApp chat group, but you can also send us an email at clinics@webinars.co.za, or you can send them directly to me, rbilla, B-I-L-L-A, rbilla, at clinics.co.za. Yeah, thank you very much. And so this evening, we were excited that we have one of our professionals, Dr. Dineo Tshabalala, who is part of the medical oncology department at the Charlotte McClurg Johannesburg Academic Hospital. And she obtained medical training at the University of KwaZulu-Natal and obtained an MBCHB, and then also qualified as a specialist physician from the College of Medicine of South Africa, and completed a subspecialization in medical oncology in 2012. Outside of a current focus in oncology, Dr. Tshabalala has acquired the necessary clinical experience ranging from outpatient and inpatient management, medical emergencies, and critical care in the various subdivisions of internal medicine. And since July 2015, she has worked at the Department of internal medicine as a consultant in the Division of Infectious Diseases, exploring other passion in clinical research and drug clinical trials to enhance oncology care. And Dr. Tshabalala is also involved in teaching at a current hospital, an activity that she enjoys. And we are glad that through the assistance and help of MSD, we're able to get Dr. Tshabalala to speak to us this evening. So I'm going to ask Dr. Matibandela to just 1 minute, just to share a few words before we then hand over to Dr. Tshabalala to give us a talk.
Thanks a lot, Dr. Bila, for the introduction. So my name is Mashudu, and I'm with the medical department at MSD Pharmaceutical. So for us, it's a great opportunity to partner with clinics in such an exciting and very educational webinars that have been happening for the past 3 years. And we look forward to this future relationship going forward. And I hope everyone enjoys the meeting, and all the best to Dr. Tshabalala. Thank you.
Thanks, Mashudu. Just to indicate, colleagues, that we struggled with Dr. Tshabalala to get a video, so she won't be showing a video because we've got some logistical challenges, but the presentation is ready. So we're going to then hand over to Dr. Tshabalala to then do a presentation on breast cancer disease overview. Welcome, Dr. Tshabalala. Thank you very much for being with us this evening.
Thank you, Dr. Bila. Good evening to everybody. Am I audible?
Yes, you are. You're audible. Yeah.
And thanks for the wonderful introduction. I actually qualified as a medical oncologist in 2018, not 2012, but everything else is correct. And if anybody has any pointers as to how I can share the video, I'd really appreciate it. My only problem is if we have to restart, my computer might be a bit slow. But if it's okay with everybody, can I start presenting without me showing on video?
No, go ahead.
I've already been introduced, so I'm going to go on and share my slides and my presentation. So the disclaimer is that to just kindly note that the views and opinions of Dr. Tshabalala, the speaker, and do not necessarily reflect those of MSD, although I'm partnering with them tonight. So this is just a brief overview on breast cancer. In this forum, I think it's very important because it is the most common female cancer diagnosed worldwide. And it's important that we have these discussions and as clinicians, because it impacts a lot of our female patients. And we see a lot of these patients, and we see how we could improve on, number one, the screening, the diagnostics, and the treatment or management of these patients. So as I've said, globally, it's the most diagnosed malignancy. In our National Cancer Registry here in South Africa, it's been said to be the #1 diagnosis in females. And this was from the last National Cancer Registry statistics in 2019. In the USA, 260,000 new cases are diagnosed yearly, with 40,000 deaths each year. And this is from the GloboCan, the most recent GloboCan statistics that were reported in 2020. It's important to know for all of us that, yes, we are mostly in a resource constraint environment, but screening plays a very important role in making these diagnoses in our female patients. And if we could improve in this and improve it in our primary healthcare facilities, then it would really go a long way for the management of breast cancer, and it could reduce the morbidity and mortality that we're facing from breast cancer. So there's different pathologies in breast cancer. You know, it's not just one disease. It doesn't present the same across the board in every female patient. There's luminal subtypes, which are the most common types of breast cancer that we will encounter. There's HER2 enriched subtypes, and there's basal-like subtypes. which we refer to as triple negative breast cancers. But it's important to know as well that not all basal-like subtypes will be triple negative, but more than 70% present as triple negative. About 10 to 15% will be HER2 enriched, and then 5 to 7% are luminal subtypes. But by far and large, basal-like subtypes of breast cancers are triple negative. There's other types of cancers that can occur in the breast, which can occur as a sarcoma, as a malignant phylloides tumor, or lymphomas can also primarily originate from the breast tissue. There's also in situ breast lesions known as DCIS, ductal carcinoma in situ, or LCIS, which is lobular carcinoma in situ. It's important to know when it's DCIS or LCIS, because the management that you will partake in or rather, for lack of a better word, the management process in these patients is different to invasive carcinomas. And also with these DCISs, when you screen the patient or when you're working up the patient, if there's anything suspicious in the axilla, then it's more than just a pre-invasive carcinoma like a DCIS or LCIS. You need to look for microinvasion or invasion in the axilla. You will never have DCIS or LCIS in the axilla. So when you find a diagnosis and you take the histological diagnosis that you've gotten and it says it's a DCIS or LCIS, and you compare it to your mammogram or ultrasound, and there is involvement of your axillary lymph nodes, you need to search for either microinvasion or invasive disease, because LCIS and DCIS will never present in the axilla primarily. So workup and investigations, as I said, when we do get these patients, they come into us, they're presenting with breast lumps. We often see patients presenting at later stages because there's been a delay somewhat in getting to the final diagnosis. Either the patient has been breastfeeding and she's got a lump in the breast and she's turned away and given antibiotics and told that it's probably just an infection, an abscess, because she's breastfeeding. And then a year down the line or 6 months down the line, the patient presents and she's actually got invasive breast cancer and she's already metastasized. So I think we need to err on the side of caution and be more sensitive to our patients that are presenting to us. Any healthcare professional can make this error, but with the prevalence being so high, I think it's very important that we rather over-investigate than under-investigate in these patients. So if a patient comes in, there's a breast mass, let's rather think cancer than not. Let's not turn the patient away. So obviously, baseline, you do a mammogram, although it's important to note as well, mammograms are specific or rather sensitive in older females because they've got less dense breast tissue and they've got more calcifications in the breast, so you can pick up the abnormalities. The younger breasts are more fibrous, it's more fibrous tissue, and you can miss a cancer in those breasts. So you would do a mammogram. In addition to that, you do a sonar of that breast. However, sometimes even with these two modalities that should define the lesion in that breast and that in the axilla, sometimes for smaller lesions or in younger females or in older females as well, where you can't really define what's happening, it's always best to send this patient for an MRI. And if you're not able to, rather refer to an oncologist or a breast surgeon, specializes in breast surgery and can send this patient for the MRI, because we obviously know medical aids will also give us problems. But if this patient is sent by a medical oncologist or a breast surgeon that does this every day, then we can better define what's in that breast and treat the patient appropriately. The mammogram and sonar would be followed by a biopsy of the breast lesion, which will then tell us what's happening in that breast. Is it benign? Is it malignant? Is it pre-malignant with your DCIS or LCIS? Staging also plays an important role, especially in our HER2 positive breast cancers and our triple negative breast cancer patients. It's important to note that even if they have small lesions, T1s, T2s, they are still at very high risk of metastasizing. So if you have a patient that's HER2 3+ on immunohistochemistry or the FISH in situ hybridization confirms that it's a HER2 positive breast cancer, or it confirms that the patient is ER negative, PR negative, and indeed HER2 negative, then please rather do baseline screening and staging, because these patients will, in most instances, present with metastatic disease. So you do a CT scan, a bone scan, to just know what the baseline disease is in this patient, because most of these patients see surgeons first, and surgeons go ahead and do the surgical management. And in fact, we know that if you're going to operate on a metastatic breast cancer, there is no benefit, because there's no overall survival benefit, even if you remove the primary lesion. So if you know that this patient's metastatic, even if it's a T2 lesion, you'd rather than send this patient to a medical oncologist who will then manage this patient further, then going ahead and cutting a breast, and the patient later knowing that there's no benefit in the breast being removed in the first place. Then we'll go into a bit of a discussion about the different breast cancers. We know there's luminal type breast cancers, which account for 75% of all breast cancers that are diagnosed. There's luminal A breast cancers, accounting for 50 to 60% of luminal type breast cancers, and they usually occur in older females, but they do also occur in younger females, just on a smaller scale. They have a low histological grade, so often when we explain it to our patients, we call it a sleepy cancer or more indolent cancer. It can grow slowly for many years, until it metastasizes. They've got a very low mitotic activity. How we view the mitotic activity on our histology is that the pathologist will then count the proliferation index, called the Chi-67 score. At the latest guidelines of when to differentiate between luminal A and luminal B, according to WHO, is 20%. So the 20% marks differentiates whether you're luminal A or luminal B. But the true luminal A breast cancers are those that have a Chi-67 score of about 5-10%. Anything less than 10%, those are true luminal A's, and they will behave as such. Very slow growing. The patient will tell you, for the past 3 years, I've had this lump and it's grown ever so slowly. And also they'll take very long to metastasize. And when they do metastasize, it will be first to bone. It hardly will it be first to any visceral organ. Then you have luminal B breast cancers, which account for 15 to 20% of the luminal type breast cancers. And majority of the patients that will present with these types of luminal B breast cancers are young females. It's a very high histological grade. So when you see your report, your pathologist report, it'll say it's a grade 2 or a grade 3. Hardly will it ever be a grade 1. The grade 1s are for the luminal A's. It has a higher mitotic index, so anything more than 20% will be a luminal B breast cancer. They've got a higher propensity of recurring. They've also got a higher propensity, even when treated, to recur. And this is mainly because these cancers develop mutations in the cascade, and they have mutations in other pathways like the PI3Ks and the P10s, and then that's what makes them more aggressive and more with a higher incidence of metastasizing. We then have HER2 positive breast cancers, which account for 20% of our breast cancers. We also know that from studies that have been partaken with neoadjuvant, adjuvant chemotherapy and your metastatic setting, that your hormone receptor negative HER2 positive tumors in general respond better to your treatment, your chemotherapy, and your monoclonal antibodies that are directed to the HER2 receptor. They do better than your hormone receptor positive, HER2 positive breast cancers. And in these cancers, especially in the neoadjuvant setting, achieving a pathological complete response, which is this PCR that I've written, is a predictive marker for overall survival and event-free survival. So if you do achieve a pathological complete response from your neoadjuvant treatment, you're bound to get better responses. You're bound to achieve results that can lead you to doing more breast conserving surgeries than total mastectomies, and the patient can have very good overall outcomes. The HER2-directed therapies are different, but it's important to note that when we talk about luminal A and HER2-positive breast cancers, they've got wider range of directed therapies or targeted therapies that you can use. Yes, I'm going off a tangent and I've left the luminal type of breast cancers, but for luminal breast cancers, we've got many agents that we can give down the line if the patient progresses. With HER2 as well, in the neoadjuvant setting, we've got trastuzumab, which you can either give on its own or give it with pertuzumab. Of course, we need to be cognizant of cardiotoxicity of these agents, especially if you're going to give them with anthracyclines. So in your diabetics and in your patients with underlying hypertension or any risk factor for increasing your risk of cardiotoxicity, you'd err on the side of caution and rather maybe give a single agent of your trastuzumab with a non-anthracycline regimen. But the best results were seen when you were giving a combination of trastuzumab with pertuzumab together with your chemotherapy. And of course, in most of the trials, there's a lot, Trifina, Neosphere. There were some attempts to try and decrease the cardiotoxicity. For instance, we know in Neosphere that given anthracycline, and then they'd follow it with the taxane. And when you got to the taxane part of the treatment, then you'd add the trastuzumab and pertuzumab to just give your cardiac muscle a break, so that you don't cause too much toxicity and damage the cardiac muscle. And in Trifina, they tried to see if you used a non-anthracycline regimen, would you be able to decrease the cardiotoxicity seen when you were giving anthracycline plus these monoclonal antibiotics that are targeting HER2. We know that in the adjuvant setting, there is a role post giving your trastuzumab. There is a role for giving either TDM1, which is trastuzumab, but plus amtasen, which is a drug conjugate that's added to the trastuzumab that just enhances the mechanism or the function of inhibiting that HER2 receptor when treating patients. So with the TDM1 inhibitor, they gave addition of 12 months of a TDM1 post your primary neoadjuvant therapy. And this showed that these patients had a better progression-free survival and decreased the risk of progression or death. And also with neratinib in the Expedite trial, they gave neratinib post your treatment that also improved the outcomes of these patients. In our setting, most of the patients will present metastatic with HER2 positive disease. And the first trial that showed benefit in these patients was the Cleopatra trial, where they gave a taxane with trastuzumab and pertuzumab, and it showed an overall, not an overall survival benefit, but a progression-free survival benefit. Amelia was known as second line to Cleopatra, where a TDM1 inhibitor was given after trastuzumab and pertuzumab. But now Destiny Breast 03 came out not so long ago and showed that the new second line treatment would be an agent called trastuzumab deruxtecan. So then your TDM1 will fall into third line. And there were other trials that showed, like your HER-CLIMB, where you can give another agent called tucatinib with the trastuzumab and capecitabine, and especially patients with brain metastases would benefit from the tucatinib trastuzumab combination. We also know that breast cancer can very well occur in male patients. More than 95% of male breast cancers are of luminal subtype, and breast cancer is prevalent in plus minus 1% of males in Western countries. There's a slightly higher percentage, 5% in the Central and Eastern African countries. And this is thought to be related to some risk factors, like there's genetic syndromes that can occur in these patients. And there's also a higher estrogen to androgen ratio, that some drugs, some herbs, liver disease, and Klinefelter syndrome has been shown to increase the risk of breast cancer. Also, if there's a positive family history, especially if there's the BRCA gene that's prevalent in the family, then these males will be at increased risk of developing breast cancer. Also important to note that there hasn't been a lot of evidence as to is breast cancer treated differently in men than females. So all the guidelines are taken from the female guidelines and applied to male guidelines. Most of them are luminal subtypes. So if they need any systemic therapy, that get either hormonal therapy if they're luminal A because it's better responsive, or they'd get chemotherapy, go through surgery, and then get radiation therapy as the females would do. Then triple negative breast cancer accounts for 15% of the breast cancers that we will see. But to note, it is the most aggressive type of breast cancer that a female patient will present with. So the earlier this cancer is picked up and the earlier this patient is referred to an MDT, it's better, because these tumors will present with tumor expression of ER negative or ER positive, or express less than 1% of ER and PR, and they will be HER2 negative. So when HER2 is 1+, it's also negative. And it usually occurs in younger females, younger than the age of 40, more in Black females than in white females. And patients that present with triple negative breast cancer, most of them will have a BRCA1 gene mutation that's positive. BRCA1 more than BRCA2, but it's important that if you see any patient under the age of 55, you test them for the BRCA gene, and you'll see later on why it's important to know whether the patient has BRCA positive gene mutation or the patient is wild type. Wild type means they are negative. And also we've seen that because in triple negative breast cancer, we don't have any targeted therapies, we've picked up that if you do a PD-L1, it's important to test the PD-L1, because then we've seen that if you treat these patients with immune therapy, they've got better responses. So there is some glimmer of hope for treating these patients now. So if you look at the molecular and pathological features of triple negative breast cancer, you'll see from now onwards, I'm gonna just concentrate on triple negative breast cancer, because I think, it's important that we just put a bit of a magnifying glass on this type of breast cancer, because we're seeing a lot of females presenting with this type of breast cancer. And I don't think we've reached our optimal management protocol or approach when treating these patients. So usually on immunohistochemistry, there'll be, as I said, estrogen and progesterone receptor negative, HER2 negative. They'll have cytokeratin. So sometimes the patients will present and the histology will say it's an adenocarcinoma, and you often see the pathologist will go do ER, PR, HER2, and they'll do these cytokeratin markers, cytokeratin 5 and 6, and they'll also add a Vimentin, which will show them that it's probably a triple negative breast cancer rather than a breast cancer metastasizing to the breast. They're usually very high grade on the pathological characteristics. As I said, high proliferation index, and they're very, very aggressive, and it's important to test for a germline mutation. They're usually ductal carcinomas, but they can also be metaplastic in histological subtype. And this is just to show you that the distribution, the racial distribution, if you look, when I'm looking at the screen, on your right-hand side, it's usually African, African females that are usually affected the most by this cancer, triple negative breast cancer. And it's also important to know that it's been shown, just like lung cancer, triple negative breast cancer is not one disease. It's very varied. There's basal-like breast cancer, which is more aggressive. There's luminal androgen type of breast cancer, which will usually occur in older females. And it's been shown that in these patients, if you treat them with anti-androgens like bicalutamide that you use in prostate CA, they respond very well. And also when you give some of these patients with the less indolent type of triple negative breast cancer, when you give them just a chemo tablet like capecitabine, they respond remarkably. They can even have a complete response on just these agents that are less toxic than chemotherapy, than the intravenous chemotherapy. But it's important that we start looking more into what type of triple negative breast cancer does this patient have, because it's not one disease. It's very varied in its presentation. And on this, this was a stats facts from the SEER statistics, where they looked at the 5-year survival rates of triple negative breast cancer. As you can see, the first block at the top, it's survival rates based on the cancer type. So if you've got hormone receptor positive, HER2 negative breast cancer, so that's the luminal type of breast cancer, you've got a 94.4% 5-year survival, relative survival rate. But if you compare that to triple negative, it's got an exceptionally low survival rate at 5 years. And if you see the survival rate of triple negative breast cancer based on stage, if it's localized, 91%, if it's distant, 12%. So it is, this is just to show that this type of breast cancer is very aggressive, and we need to be more attentive and pay more attention to detail when treating these patients. So I've got 2 cases to present of patients that presented with triple negative breast cancer. The first one was a 30-year-old female patient, para-0, gravida-0, had no comorbidities. The grandmother had breast cancer, so she's got a positive family history of breast cancer. So of course we need to think that she should probably be tested for BRCA. She presented with a T2N1 left-sided breast cancer. So this is a stage 2B breast cancer, received neoadjuvant chemotherapy, the standard of care, and anthracycline and a taxane, which is shown to have been these tumors are very sensitive to anthracycline, followed by taxanes. And then unfortunately, while receiving weekly paclitaxel, she then recurred. So the breast lesion started growing again on the same side where it started. She then was sent for an emergency mastectomy plus axillary lymph node sampling. Post-surgery, she was shown to be a T4 lesion. So from a T2 lesion, she's now T4 and N1 still. And at the time, staging was not done. She then received radiation therapy and presented 2 months post-surgery and 1 month post-radiation therapy with both ipsilateral chest wall involvement of the cancer, it had recurred, and the contralateral breast had also now developed the same cancer. And plus, when we did the CT scan, she had liver and lung mets. The second case is a 63-year-old female patient, para-4, grav-4. All her kids were breastfed for more than 6 months. Her background comorbidities were those of type 2 diabetes and hypertension. She had no family history of breast cancer. She presented de novo with a T4B lesion. Already there was skin involvement. N2 lymph nodes. She had more than 4 lymph nodes in her ipsilateral axilla, and she was an M0 because a baseline CT scan was done. Primary surgery was done of a left mastectomy and axillary lymph node sampling. She was found to have 10 out of 14 positive lymph nodes. She then went to get adjuvant chemotherapy, the standard of care. She seemed to respond very well, because you will see these triple negative breast cancers, all aggressive cancers, respond very exquisitely to chemotherapy and radiation, but as exquisitely as they respond, that's how they recur as well. She then had recurrence 1 month after chemotherapy and 10 months post her surgery. Her metastases were to the brain. She then 2 months after a month after radiation therapy to the brain, whole brain radiation, she developed lymphomatous meningitis. A few weeks after that, she then developed lung metastases. So in a nutshell, why I'm presenting these 2 cases of triple negative breast cancer is just to show you their propensity to, number 1, recur early, and number 2, to also spread or metastasize to organs, to other organs, and more frequent than not, triple negative breast cancer is going to recur to your visceral organs than to the bone. So the management of triple negative breast cancer in the early stages, I think it's important to note that even if you diagnose the cancer early, triple negative breast cancers in general have poorer outcomes. Your T1 lesions, T2 lesions, even if you've treated the patient appropriately, you need to err on the side of caution, because if they don't recur within 3 to 5 years, then you're safe. But you still have that time, that shortened disease-free interval where the patient can recur. As for the patients that, like the patients I've presented in the two cases that I've presented. Also, as I said, while treating the patient, there's a high chance, even when you've treated the patient and you've sent the patient for surgery, there's a high chance of residual disease post-initial therapy. So they've got a low pathological complete response rate, and they've got a high recurrence risk. And we've already said that their propensity of metastasizing is more to the visceral organs. So liver, lung, and brain. Survival outcomes are also very poor, despite being diagnosed early. And it's been shown that survival outcomes in early triple negative breast cancer, if you reach pathological complete response, seem to be equivalent to those patients with non-triple negative breast cancer. So if you get a patient with a T1 lesion and N0 lymph node involvement, and you have a patient with luminal breast cancer, even with a T2 lesion, if you reach a PCR with your triple negative breast cancer, your surgical histology confirms that you have a PCR. They seem to have equivalent overall survival benefit and progression-free survival benefit. It's important to also know who are the candidates that we give systemic chemotherapy to. So with triple negative breast cancer, ideally all patients that you're going to see are going to get chemotherapy, either neoadjuvantly or adjuvantly. But let's say you send a patient for neoadjuvant surgery, breast surgery, either wide local excision or a mastectomy, and a lesion is more than 1 centimeter. Please do not tell the patient it's a small lesion. You do not need any further treatment. If you've done breast conserving surgery, you just need radiation therapy. All these patients must receive adjuvant chemotherapy. So the best treatment approach is to say all these patients must be sent to a multidisciplinary team meeting so that they can be discussed and a management plan can be appropriately set out for every individual patient that you see. Every patient that has a tumor that's T1C and more is going to obviously receive neoadjuvant chemotherapy to downsize and obviously try and reach a pathological complete response, and because we know the outcomes are better. So for triple negative breast cancer, there are no targeted therapies thus far, like we've seen in luminal type breast cancers where you have CDK4/6 inhibitors. Recently, they've got PI3K inhibitors. You've got in your early stages, either your SERMs, your selective estrogen receptor modulators, or within your form of tamoxifen, or you've got your aromatase inhibitors. In triple negative breast cancer, all we've had thus far is chemotherapy. And because they've been responding so well, we've been happy with chemotherapy. But for those patients who recur, you just continue with chemotherapy with no end in sight. But now we know that we're able to test for PD-L1 in these patients. And what they do with the PD-L1 is use a score, a CPS score, where they look at the number of immune cells over the number of tumor cells that are positive for PD-L1. There's a maximum score of 100, and any score that's more than 10 is a significant score. And it's been, and you'll see in the studies, it's been shown that patients with a score more than 10 will respond better to immune therapy when in combination with chemotherapy. And in the studies, it's been also shown that when you give chemotherapy, patients that are BRCA positive will respond better to platinum agents than to your anthracyclines and all your other chemotherapeutic agents. So that's where your BRCA-ness also plays an important role. So test for PD-L1, and it's an immunohistochemistry test, so it doesn't cost too much and it doesn't take too long. So when they are doing your immunohistochemistry for ER, for PR, for HER2, ask them to also add a PD-L1 because it's an immunohistochemistry test. And we know that the treatment, the standard of care at the moment for these triple negative breast cancers, as for the latest Keynote 522, has shown to be a combination of chemotherapy plus immune therapy in the form of pembrolizumab. These patients have had not exquisite, but they've had good results compared to what they used to have on chemotherapy. Their pathological complete responses have been better. Their disease-free intervals and their overall survival has also been remarkable. With the pembrolizumab and chemotherapy combination in the Keynote 522 trial, it showed that the PCR rate was 64.8% versus 51.2% with chemotherapy and placebo. So we've seen that there's improved PCR rate, and this was shown across the board in patients that had exquisite PD-L1 CPS scores, and for those that didn't have CPS scores of more than 10. So across the board, if you add pembrolizumab to your chemotherapy as neoadjuvant therapy, you get good results. And it's been shown, as I said initially, good PCR rates equals good outcomes in disease-free interval, recurrence, and overall survival. So in these patients with triple negative breast cancer, once they've received their neoadjuvant chemotherapy and they have residual disease, even after giving your primary chemo, it's been shown that in the CREATE-X trial, if you don't have your pembrolizumab, there's also a CREATE-X trial which shows that you can give adjuvant capecitabine for 6 to 8 cycles to just try and improve your disease-free interval and improve on overall survival. I'm just going to go back a little bit. In your 522 trial, after they had received pembrolizumab and chemotherapy, gone for surgery, and after surgery, they continued with pembrolizumab for a total of 1 year. So it also helps to increase that disease-free interval and overall survival ratio. There's then we CREATE-X, if you don't have your pembrolizumab and you've given chemotherapy, you've got a chance of increasing that disease-free interval by giving capecitabine as per CREATE-X trial. There's been other adjuvant settings that have been also been on clinical trial, giving PARP inhibitors for patients that are BRCA positive. Your BRCA-ness comes into play here, so it's important to test for it, where your patient has completed all the neoadjuvant treatment, chemotherapy, surgery. Then you can give olaparib, which is a PARP inhibitor that is more sensitive in BRCA positive patients, and they would give that for 12 months, and it showed also positive benefits in increasing your disease-free interval. When we come to the metastatic setting, also it's important to know that most of our patients in our setting will present de novo metastatic. But if you look globally, metastatic triple negative breast cancer accounts for approximately 5 to 10% of our patients that present with de novo metastatic breast cancer. But just to err on the side of caution, please, even when the patient has a small breast lesion and suspicious, very small lymph nodes, let's rather stage them at baseline. And we know anyways that they're more prone to having visceral mets. So just do a simple CT chest, abdomen, pelvis, just to check that there's no metastatic foci. And we've already said that less metastases to bone, more to viscera. These tumors, just like the lung cancer, have high tumor mutational burden, high tumor infiltration lymphocytes, and high PD-L1, and they are prone to having a PD-L1 positivity than other types of breast cancers. If your patient's medical aid is not able to pay for PD-L1, then ask the pathologist to do TILs, because the higher the TILs, it shows that the better the response to treatment that these triple negative breast cancers, the higher the TILs they have, the better the response to treatment, even just chemotherapy. Again, in metastatic triple negative breast cancer, the standard of care is still chemotherapy, but we know that the new standard of care should be pembrolizumab with chemotherapy, because since the latest keynote trial, the 355 trial, we know that it was approved in November of 2020, that the new standard of care should be pembrolizumab with chemotherapy, because then there's better responses when patients get immune therapy plus chemotherapy. So there's been 2 trials that have shown that possibly the new standard of care in triple negative breast cancer in the metastatic setting should be immune therapy with chemotherapy. There was the Impassion trial, Impassion 130. So Impassion had 2 trials, Impassion 130 and 131. But I won't speak on 131 because there was no benefit seen in Impassion 131. So the difference is that in Impassion 130 and 131, in Impassion 130, they used nab-paclitaxel, which is a protein-bound taxane. So the paclitaxel is bound to a protein. And the paclitaxel is just the naked molecule that's not bound to any protein. So in Impassion 130, they used atezolizumab, which is a monoclonal antibody against PD-L1. And it was shown that there was a 20% reduction in risk of progression of disease or death when patients with metastatic breast cancer had neoadjuvant atezolizumab plus chemotherapy, or even if they were treated previously with other agents, they still had a 20% reduction in risk of progression or death. The progression-free survival in these studies was 7.5 months compared to 5.5 months when the patients had chemotherapy on their own. And also, if they were PD-L1 positive, these patients had a 38% risk reduction of progression or death. So in all the patients put together, those that were PD-L1 positive had better responses when they got this combination of atezolizumab plus chemotherapy, as shown by the median 7.7 months of in PFS and 3.9 months in chemotherapy alone. The latest Keynote 355 study showed even better results. In this study, there were patients that were either locally recurrent and were not amenable to resection, or they were metastatic and they had a histological confirmation of triple negative breast cancer. They were given pembrolizumab plus chemotherapy, and the chemotherapy arm varied. Some got paclitaxel, some got nab-paclitaxel, some got platinums. So the platinum arm was gemcitabine and carboplatin. And across the board, when any of these agents, chemotherapeutic agents, were given in combination with immune therapy in the form of pembrolizumab, there was a benefit in your progression-free survival of 9.7 months versus 5.6 months. We are still awaiting overall survival data, but I'm sure the overall survival data is also going to be remarkable. However, in this cohort of patients, the patients that got the most benefit were those that had a PD-L1 CPS score of more than 10. So I think if they do the subset analysis, when we do get the overall survival data, they'll tell us about how the benefit in the patients that got CPS scores of less than 10. So you can see that in both these studies, we've been shown that for the longest time, triple negative breast cancer has had no targeted therapy. But we can see that if you combine the immune therapy with the chemotherapy, there is a better benefit than what we got with chemotherapy previously. And it's better to treat the patients with immune therapy and chemotherapy in the first line setting. So de novo metastatic, don't try chemotherapy before you give the immune therapy, because the overall survival benefit and the progression-free survival benefit is better if you give it upfront before they develop more mutations. Because in this type of breast cancer as well, you've got the propensity to have other pathways and mutational pathways showing up, like your PI3 kinase, PI3K pathways and other pathways, P10 pathways that render this cancer more resistant to any form of chemotherapy if you delay giving this chemotherapy immune therapy upfront. This is just the summary of what I've just spoken about with the Impassion 130 and 355. As I said, we are waiting, but I'm sure at the ESMO Congress now in September, we'll get all the final results for the Keynote 355. This is just the Kaplan-Meier survival curve that just shows estimates of survival at different stages for triple negative breast cancer versus non-triple negative breast cancer. If you see at stage 1, a non-triple negative breast cancer and a stage 1 of a triple negative breast cancer, the survival is, if you check the curve starts slanting down, which decreases the survival of just the stage 1. And if you look at stage 4 compared to stage 1, look at that survival curve at the bottom. Look at the green one for stage 4, look at the blue one for stage 4. These patients do not stand a chance if they come de novo metastatic. So we definitely need to treat and or screen and catch these patients early and refer as early as possible so that we can try and prevent them from getting to stage 4 if they present with earlier stage disease. And the crux of this talk is to just emphasize that our multidisciplinary team management meetings play such a vital role for all our breast cancer patients, irrespective of what type of breast cancer or what subtype of breast cancer the patient has. This gives us the opportunity to individualize each patient's care, improved decision-making. And in an MDT, we have different schools of thoughts, but we put our heads together and we try as best as possible to treat these patients according to evidence-based medicine, not a decision that I make on my own as Dr. Tshabalala because Dr. Samuels or whoever has referred a patient to me and I want to keep this patient and I want to do what I think is right. We need to adhere to prescribed guidelines. We need to know that there are more than enough of us to collaborate, and the more you collaborate, the more the patients are, if you're the surgeon and the patient is referred to you from the GP and you send the patient to an MDT discussion, the more you send your patients, the more your patients will return to you as the surgeon for you to operate on the patient when the patient has been cytoreduced effectively and we know that we're now safe for surgery. It's important to collaborate. So each and every one of us are able to refer our patients efficiently. We're able to know how to have a good management approach for each patient. What type of biopsy is needed? Do we need to biopsy the axilla because it looks suspicious? Do we need to, in addition, do an MRI? Because according to an observational study that was done, it's been shown that patients that actually are managed under an MDT management team have a 15.6 higher survival at 5 years than those that have never been discussed at an MDT. So we need to improve our triple negative patient outcomes, but not just our triple negative patient outcomes. Our HER2 positive breast cancers, our luminal B breast cancers, because there's some luminal B breast cancers that behave so aggressively that we need to start, being cognizant that we all need to be a team and we don't need to hog on patients. We don't need to be shy if the evidence is not known. We need to just share ideas, and more importantly, if you see a patient with triple negative breast cancer, HER2-positive breast cancer, please rather refer first either to an MDT that you know, or refer to an oncologist that you know, who will discuss it in a multidisciplinary team management meeting. Also, let's start having multidisciplinary teams in each of our hospitals. It doesn't take a lot. These days, we don't have to be face-to-face. We can do it virtually. We can have a 30-minute, an hour discussion, depending on the number of patients we have, and just, you know, play around with ideas and do the best for our patients. Thank you.
Sure. Thank you very much, Dr. Tshabalala. Such information. It's been a good evening. I saw someone, I've forgotten the person, who said, I'm so much looking forward. I think Dr. Mtembu wrote today. You might know Dr. Mtembu, I don't know. So I'm so looking forward to this presentation this evening, and I can attest that it was worth waiting for it. And thank you that you give such a wonderful talk and a lot of research information, new information. I think that's what excites about this webinar, that you come in and get new information. It's not only about getting to know what you know, but it's also obtaining up-to-date information. And I see Dr. Hoss says, thank you, Dr. Tshabalala, excellent presentation. You said the crux of the presentation is about MDT, that, you know, we need to work together. I wanted to ask a question. I don't know how to put it, you know, because, you know, you've got academic settings where it's easy. You've got all the disciplines together. And I think by the fact that, you know, where you work at Charlotte McClurkin, it's easy to organize an MDT. But in a regional hospital or in the private sector, you know, a hospital that is a standalone, in one of the groups, we've got so many healthcare groups. And how do you encourage a situation where there is collaboration amongst these different specialties within each one of the hospitals, where you don't have, maybe even an oncology unit for that matter?
Thank you for your
and after that, I'm going to ask Dr. Tulan, who's one of our, I think, the first Black surgeon, who's also is a breast surgeon herself, to give a comment also after you've made your comment.
Thanks for your question. It's actually a very good question, and I'm glad you asked that question, because it's very unfortunate that we lost one of the breast surgeons who we had at Charlotte McClurkin, who was very enthusiastic, Dr. Boitumelo Phakati. We've lost her to UKZN, but she had actually started recruiting some of the smaller regional hospitals. She started with Pulusong, started a breast unit there, and Dr. Kilani is currently heading that. So I think the more I can share my contact details with the other breast surgeons, but I think as a tertiary quaternary hospital, we also need to reach out to these primary healthcare facilities and these regional hospitals, because they can join our MDTs. We have multidisciplinary team meetings. For instance, the breast meeting is every Thursday at 8 a.m. Pulusong has joined us. Pulusong has got a breast unit now headed by a surgeon. And we can add on the other regional hospitals. And, you know, even for training purposes, for instance, we've got very good breast surgeons that can collaborate with the other surgeons and teach them newer techniques, take them along when they go to these congresses, Sant Antonio, which is usually in Austria, or, you know, other congresses that they have, so that they can learn about newer techniques of surgery, or they can join the MDT, or they can join some of the sessions when the surgeons are operating on our state patients. So I'm more than happy to collaborate and add some of the surgeons to our MDTs. On a Monday, we've got a GIT MDT discussion which is headed by Dr. Marumo and Dr. Pradal. So there are many MDT discussions that I'm more than happy to include all the surgeons in. And I think the days where you're shy that you don't know, or you're shy that, you know, you don't want to be involved because you've left state, the same principles that we apply in the state setting are the same principles that we can apply in the private sector. And these MDTs have helped me as an oncologist so much, because you get a better understanding how to individualize each approach for each patient, whether it's for breast cancer or colorectal CA or gastric CA. So I'm more than happy to share my email, my details, and I'm more than happy for any of the surgeons to join all the MDTs that we have in state and in private. The MDT that I follow at the moment is the one with Prof. Ben at Moorpark, but she does it across the board, and they're more than happy in that MDT to also collaborate with Prof. Rappaport and them. They're more than happy to collaborate so that we can, the aim is to just give better care to our patients.
Yeah, that's I think the same approach that's what we're there for as clinicians, and also with administrators, to make sure that our patients get a good quality care. Dr. Tshabalala, you want to make a comment?
Okay, good evening to everyone. And I enjoyed the presentation by Dr. Tshabalala. Thank you very much. I think there's nothing more to emphasize than the multidisciplinary teams that need to be established. And that's the only way to go. Breast surgery has become, breast cancer management is very specialized now. And you can't just treat a patient in isolation. Every patient by right must be discussed in a multidisciplinary meeting. And that will alleviate a lot of problems, because as a surgeon, for instance, I mean, and that should include radiologists, surgeons, oncologists, plastic surgeons, etc. And right now, the problem that I see is getting lots of referrals with patients who are even just investigations that are wrongly done. She talked about a mammogram, for instance, whether she talked about axillary lymph nodes, whether they should be biopsied or not. And I still see a lot of patients referred by GPs with a mammogram where somebody just writes, there's an axillary lymph node, doesn't comment whether this lymph node is suspicious or not. The standard now is that if you see a lymph node, you must examine it. And there are features on ultrasound that will tell you whether this lymph node is suspicious or not. If it has a thickened cortex, if it has lost its fetus hilum, if the edges are irregular, that makes it suspicious. You need to biopsy it so that we know whether this node is positive or not. So what you find happening is that a patient will come with a mammogram that is not clearly explaining everything that you need explained, and you have to send a patient for another investigation. So we're actually wasting resources because people are not keeping in touch through multidisciplinary meetings to know what needs to be done. And even when it comes to surgeons, we do find that patients are managed wrongly and mismanaged at times because people are not part of multidisciplinary meetings. And so it's very, very important. I think that's the way to go, that we should try and establish multidisciplinary meetings. I work in the military hospital. There's an oncologist that we work with, and we always discuss all patients. But also because in the military we have a problem with theater, I operate at Lymph Kloof. Every Tuesday, every patient is discussed. So the military patients get discussed at Lymph Kloof. Every Tuesday there's a meeting, and any mammogram that is positive is discussed. And so that helps in my management, because whatever decision is made is not my decision alone. So I think that's the most important thing, making sure that we set up these multidisciplinary meetings and trying to make sure that we accommodate everyone.
Thanks a lot, Dr. Tula and Dr. Tshabalala. Any further comments, colleagues? Anyone who's got a question to ask Dr. Tshabalala? And I see someone who's a GP who says, this is very, Dr. Lambert says, quite a great presentation. very informative, important points, tips for GPs. We can now advise patients in more greater detail. I think that has been quite helpful. Anybody else who's got a question to ask colleagues? And how you say the MDTs are quite open, and the GPs, how do you get involved? How do you involve GPs? Because someone sends a patient to a surgeon, and then they need to get feedback, and how can they be part of that MDT if they want? You said they're quite open to join you, even as GPs.
So in most instances, the GPs are going to send patients to private practice, but if they want to send to Charlotte, usually they send via the breast surgeons anyway, so those will be discussed. If it's in private, I know Clinics is starting a breast MDT very soon. And then if the surgeon is sending to the breast cancer center of excellence with Prof. Ben, the GPs do join. If you've got a patient, then on that week you do join the MDT discussion for your patient. But I feel if the clinics group starts that breast cancer MDT multidisciplinary team management forum, then on the week when the specific GP or a number of GPs have patients, we should involve them in that MDT. So it's just dependent on when that GP has a patient involved for the particular week. Then we can just stagger them and involve them in the MDT discussions. It's very, very important.
No, that's great. Yeah, I think just watch the space as soon as that that unit is up and running. We'll communicate and inform all our colleagues, the GPs who are operating within our drainage areas in Soweto, the Val, and Ekurhuleni.
And sorry to interrupt, but I know MSD is very, very involved in the MDT discussions as well. So we can involve Mashudu to just please alert his bosses that you guys will have an MDT. They'll support you. They'll definitely support you. Yeah.
Any comments, Mashudu? Dr. Tshabalala, from your side. I like this discussion tonight. It's a presentation with an outcome. Because we shouldn't just be having conversations, but there's no outcome out of these presentations. And I think it's good that we seem to be making headway out of this tonight's discussion too. Doc.
Yeah, no, definitely. I think Dr. Tshabalala is quite right. It's something that came out from a meeting that we've had with a number of oncologists. It was an EIF, External Input Forum meeting. And it's something that they requested from our side, if we can actually become partners or collaborators in the MDTs, especially in also those institutions that want to establish new MDTs so that we can support. So it's something that from us, we are working closely with some oncologists who have raised that. So we'll be very open to also support the clinic's MDT that is being planned, and I think we can have this discussion post this meeting to see where we can be able to help from our side. But it's something that we are really keen on supporting from our side.
Thanks a lot, Mashudu.
Yeah.
Dr. Tshabalala, I don't see any further questions or comments, any parting shots from your side? You've given us a mouthful tonight.
I think Aswin Dini asked what my approach would be to prophylactic mastectomy in BRCA-positive patients. Yeah. So you need to individualize this, there's a lot of controversy, and yes, you can if there's a strong enough history and the patient is BRCA positive, you can have that discussion with the patient, and it's probably the best way to go for these patients. But it's also very individualized. You wouldn't just across the board, or do mastectomies for these patients. But it is a good point that you raise, and it is individualized. They have a higher risk of developing breast cancer. And if there's a family history, then yes, prophylactic mastectomies are the way to go, or close monitoring. If the patient is a bit skeptical, rather do close monitoring. And if at the highest index of suspicion, then rather go for surgery, the surgical approach.
No, thanks for that, Amish. There's also a question from Dr. Bongani Mthembu. The doctors in the primary healthcare setting usually find breast lesions or lumps and then refer such patients to a higher level of care. They are usually encountered with resistance from the referring institutions. The excuse is usually that the patients are not properly worked up. How best can we expedite the diagnosis and management of breast cancer in the public sector? Are there any referral protocols or structures in place that you can share with us?
So in Johannesburg, the two referral centers, and Johannesburg, it's Pulusong now, which has a breast cancer center. It's Joburg Gen, and it's Helen Joseph. I know Joburg Gen every Friday, even if you just send the patient, they're open to seeing every patient on a Friday. I can't speak for Helen Joseph and for Pulusong. And obviously there's a drainage rule. You refer according to where you live, that drainage area rule. But what I'm willing to do this Thursday when we have the next MDT is just to remind all our clinicians to just be cognizant that GPs are always trying to refer patients to the public sector that don't have medical aids. So we should be more welcoming to get those patients into our system and treat them as soon as possible. But on a Friday at the Gen area 348, any Friday you can send a new patient. And if there's a problem, I think you can always just communicate with me and I'll communicate with those breast surgeons. I think Helen Joseph has a clinic on a Thursday. So it just depends when you send the patient. And then Pulusong, I think you can just send anytime. Dr. Kilani is very enthusiastic and willing to help patients.
Okay. Perhaps if you write okay, maybe we can just share your email address. Alternatively, you can just put it on the chat group, your email address, so that people who want to take it can copy it.
Okay.
Sure. Dr. Mashio is our regular. I like him. He asks good questions. Dr. Mashio wants to clarify the concept of sentinel lymph nodes in breast cancer. I remember this at medical schools.
Yeah.
Okay, Dr. Tula.
Or Tula, you want to, Dr. Mlawa, you want to respond?
Okay, I just thought maybe I should clarify that because it's what surgeons do.
Okay, perfect.
And sentinel lymph node biopsy is trying to find the first lymph node that drains that particular area. So if somebody has an invasive breast cancer, like she said, there are the in situ carcinomas. In situ carcinomas, ductal carcinoma in situ or lobular carcinoma is a cancer that's still, a ductal carcinoma in situ is a cancer that's still in the duct, hasn't infiltrated the basement membrane. So it's very unlikely that it can go to a lymph node. But any invasive cancer, so you're infiltrating ductal carcinoma, you're infiltrating lobular carcinoma, may be in the lymph node. So even if it's it's basically for early cancers where the lymph nodes are negative. So you do a mammogram, you do a sonar. Clinically, the axilla is negative. You do a mammogram and sonar, the radiologist looks at the lymph nodes, they are negative. And the patient has a proven infiltrating cancer, whether ductal or lobular, whatever. So once it's infiltrating, no matter how small it is, you need to stage the axilla. You need to find out whether that cancer has gone to the axilla or not. So because clinically and radiologically the axilla is negative, when you then operate on that patient, you will then, I personally use technetium sulfur colloid, which is a nuclear medicine material that gets injected the morning of the surgery. It gets injected periareolar, the same side of the tumor, and they do lymphatic mapping for me at Nuclear Medicine. Then they mark for me roughly where the lymph node is, but I use a gamma probe in theater to find the sentinel node. To improve the yield, when the patient is put to sleep, I inject a blue dye, same place, I massage the breast, and then when I do my lumpectomy, I then go into the axilla guided by the gamma probe and look for the sentinel node and also any blue node. So basically the principle is that any infiltrating cancer proven where the axilla is clinically negative, you need to find out whether you need to stage the axilla. You need to find out whether there are any positive nodes or not. So that is what sentinel lymph node biopsy involves. And if you found a positive node, you then go on and do an axillary dissection. I actually have a pathologist in theater who looks at the nodes. So the pathologist looks at the nodes as I take them out and tells me whether they are involved or not. Nowadays, you don't need to remove if there's just 1 or 2 sentinel nodes positive, but if there are more than that, you need to do an axillary dissection. In the olden days, with any positive node, we would then do an axillary dissection, but now things have changed. But basically, that is what it means. If somebody has a ductal carcinoma in situ, you don't need to do a sentinel, because if it's a localized ductal carcinoma in situ, meaning this is usually now patients who do screening mammograms, they see a lesion, usually DCIS will be microcalcifications. So you see these microcalcifications, you biopsy them, and it comes back as DCIS. You can do a lumpectomy without a sentinel node in those patients. However, if DCIS is widespread, again, there are patients who will do mammograms and you find DCIS spreading over an area of about 10 centimeters. So you find these microcalcifications spreading over an area of 10 centimeters. Unfortunately, you can't do breast conserving surgery in that patient because the lesion is too big. So that is the only exception. So if DCIS is widespread and you are forced to do a mastectomy, then you must do a sentinel, because when they take that breast for histology and they section it, you may have biopsied areas of DCIS and missed an invasive cancer. And if they find that you can't go back after a mastectomy and do a sentinel node, you may then be forced to do an axillary dissection, which is too much for somebody who just has DCIS. So that's the only exception. So the principle is that anyone with an invasive cancer and a clinically negative and radiologically negative axilla must get a sentinel node. DCIS is not necessary except if you are forced to do a mastectomy, then you must do it.
Thanks a lot, Dr. Dineo. That was quite an important information.
That was well answered. Thank you.
Yeah, thank you a lot. Thanks a lot. Any closing remarks? I've said that before, but maybe again, Dr. Tshabalala.
I'd just like to thank you for having me and listening to me tonight. And good evening. Yeah.
Yeah, no. Thank you very much. We just want to thank you very much for taking your time and sharing your knowledge, experience in breast, in oncology generally, and also sharing about breast disease. I think it has been quite an informative session that we received this evening. And also from your talk, there are 2 take-home messages. Is that early detection is important. I think that's simple matter that every clinician who sees patients and they suspect a lump in the breast, we said that we should not waste time, and that that's the triple negative findings that patients quite an aggressive tumor, and patients must be detected early, because if not, then the survival rates are quite shocking. That the survival rates are as the prognosis is so poor in those cases. But also the MDT, and also the fact that you have an open invitation to whoever is available and wants to come and join the MDT at Charlotte Becklage, but also that within clinics, also we're working and getting an MDT. And also thanks to Dr. Bashima Zivandila from MSD and the company for making the doctor available to speak to us this evening. we really appreciate the partnership that we're developing between ourselves and MSD, and hope that in future we'll still be able to help us source new speakers from a different wide spectrum within the medical fraternity. And also, Dr. Tshabalala, thank you very much for being available tonight and building questions and giving some advice. And we hope to engage you also to be one of our speakers in future engagements within Clinics Health Group. But also to thank everyone who's been here, those who've been joining us from the last time when we first started in 2020, that you've been with us all along and you've been supporting us and coming. And as we all normally say, Dr. Dineo, Chief of Operations, always says that please, if any one of you wants to do a presentation, give a talk, please don't hesitate. You know where we are. Send us a message and indicate that you're able to give a talk, or suggest speakers that you'd love to see giving presentations at this webinars. And to thank the leadership of Clinics Health Group. We know that we also have Dr. Tshabalala, who's a member of the board, who's here with us. And thanks for attending. Dr. Dineo was there also. And also to thank our marketing teams who has been at the background and helping put together this webinar tonight. And we just want to say thank you very much for being with us this evening, and have a good night.